Yeah. Uh, Good afternoon. I'm sorry for making you all wait. In the next few minutes, I just want to explain to you about whether it is really, whether thoracoabdominal aorta is disposable. We strongly believe that thoracoabdominal aorta has no intelligent function, and it can be easily disposed of with a simple albumin coated tube. We have been doing aneurysm surgery for the last 25 years, over 1,000 surgeries for aortic aneurysms. I'll briefly explain to you about our experience. Endovascular intervention is a turning point in the way aneurysm surgery has been done. As a heart surgeon, I don't do endovascular intervention myself, but I can see that it's a matter of time before most of the procedures will be done by the endovascular intervention specialist. He is a young man who suffers from Marfan syndrome. You can see him with all the features of Marfan syndrome. When he was 17 years old in 2001, that's about 11 years ago, he had a dissecting aneurysm, so we replaced the descending thoracic aorta. 1 year later, he had a replacement of abdominal aorta with the reimplantation of renal artery, superior mesenteric, and the celiac arteries. And when he was 24 years old, we replaced the aortic arch, reimplanted the carotids, left subclavian, and we did a mitral valve replacement with a Medtronic valve. And 8 years, 4 surgeries, he is working as a full-time engineer, and he has got no remnant of his aorta left in his whole body. His aortic valve has been removed, replaced, his mitral valve has been replaced. Essentially what he has is heart muscle with coronary arteries. Everything else has been replaced. There are a large number of patients in our country with narrow aortic root, especially young ladies. And these patients with the bicuspid valve, traditionally the valve is replaced with a metal valve using a very small size valve, even as small as 17 millimeter, 19 millimeter. But then these patients don't do very well long term because of the high gradient. The best treatment option for them is a Ross's procedure. And Ross's procedure can be done with nearly 100% success rate. The large number of patients with the diffuse aneurysm starting from the arch to the descending thoracic aorta and the abdominal aorta, the entire aorta can be replaced with a large hemartial tube. There are a good number of patients who develop, who have a bicuspid aortic valve, they develop aortic aneurysms with a leak, and they also have a coarctation of aorta. So in these patients, what we do is to replace the ascending aorta, do a Bentol, and use a separate tube to bypass the coarctation segment. We believe that endovascular intervention spoiled the party for cardiac surgeons when it is a requirement for replacing the aortic arch and the reimplantation of the neck arteries. This is a typical patient with aneurysms, and this is a typical picture of SVC syndrome due to large aneurysm pressing on the SVC with the SVC syndrome. And these patients can easily undergo a Bentol procedure. We have reduced the cost of Bentol procedure to about 1,20,000 rupees to 1,30,000 because we don't use the commercially available conduit. We use a traditional St. Jude valve, and we buy a very long tube of Hammarskjöld tube, cut it into pieces, and create the conduit ourselves. That is one of the reasons why we do very large number of Bentall procedures. This is another patient who had an operation wherein we replaced the arch of the aorta and reimplanted the neck arteries before we started the endovascular intervention. Hybrid cath lab changed the rules of the game. This is the hybrid cath lab we have from Philips. So we can do the surgery and endovascular intervention on the same table without shifting the patient. Otherwise, earlier we were doing part of the operation, then the patient was taken to the cath lab, and obviously it is not the ideal situation. We do large number of redo aortic arch replacement who had a Bentall procedure earlier, who now require an arch replacement. You can imagine a patient who had a Bentall operation, if he has to go for an arch replacement, then there is a big problem in terms of circulatory arrest, brain protection, and all the other problems. Today we do the whole procedure without using the heart-lung machine, without using a single bag of blood, virtually like a minor procedure, and the patient walks home in less than 7 days. We get large number of patients coming to us with advanced aneurysm. This is a young man who is a driver from Tirupati. He had a syphilitic aneurysm of the thoracoabdominal aorta, and the aneurysm became bigger and it was protruding from the back. He went to one of the local hospitals where they thought that it is a big abscess. So they drained the abscess. Then they saw red blood spurting out. But fortunately, there was a smart surgeon who packed the whole cavity of the aneurysm with a big swab, and you can see the tail of the swab sticking out, and he closed it and he sent the patient here. And we did the open heart surgery. We replaced the thoracoabdominal aorta, and the patient is doing extremely well. Today, we traditionally replace the thoracoabdominal aorta with the debranching of the renal, superior mesenteric, and celiac arteries. In good old days, all this were done under circulatory arrest, hypothermia, as a very major procedure. Now, our young surgeons open the abdomen, they debranch the renal artery, mesenteric artery, and they anastomose the tube into the iliac artery, and our cardiologists, they put a stent into the aneurysm. Things have become very, very simple. This is one of those patients who are branching with all these multiple branches to supply to renals and mesenteric arteries. This is how the whole procedure looks like. You anastomose the trunk to the iliac artery, bring the branches, anastomose that to the renal arteries, mesenteric arteries, and then you stent the aneurysm. This is another patient who had an operation wherein we surgically debranched all the splanchnic arteries. This is how the patient looks like. No sternal incision, only abdominal incision. There are a large number of patients who have an aneurysm of the thoracoabdominal aneurysm of the aorta, who have an impaired renal function. Now, generally it is believed that they have an associated renal disease. But in our experience, when there is a large aneurysm with the impaired renal function, you go ahead and repair the aneurysm, and when you relieve the pressure on the renal parenchyma, automatically renal function improves. This is such a patient. He is about 120 kilos. He is a pilot from Bangladesh. had a major thoracoabdominal aneurysm. He was treated in Singapore. They told him that because of the poor renal function, the risk will be high and he may have to go on dialysis. And we did the operation here. We replaced the thoracoabdominal aneurysm, decompressed the kidneys, and his renal function is back to normal. We believe that aorta arteritis can be, I wouldn't say cured, nearly cured by replacing the entire aorta starting from the arch to the bifurcation, because we believe that aorta is not required. All we need is a big tube with the side branches to supply blood to the kidneys and mesenteric arteries. There are a large number of patients with aorta arteritis who have bald arch. There are no branches. Both the carotids are gone, subclavian is gone, and they have a repeated syncopal attack. You do the imaging of these carotid arteries, and you find that there is no arteries in the carotid region. So the inference is that carotid arteries, both internal and external, are blocked throughout. This is what we believed. But in the last few years, we decided to explore the carotid arteries at the root of the neck by 2 incisions. Our facial-maxillary surgeons, they exposed the carotid artery for us, and we put a hemashield tube from the ascending aorta to the carotid arteries. We have done large number of patients with aorta arteritis with no radiologically demonstrable carotid arteries, undergoing this operation successfully, and the entire symptom of syncopal attack disappears soon after the surgery. Is there any contraindication for surgery for aortic aneurysms? There is only one contraindication, is when the patient is dead. Anybody who is alive with the aneurysm or any disease affecting the aorta can be operated and they can be nearly cured. These are our center of excellence for aneurysms of the aorta. If any one of you want to create a center of excellence, you can follow these norms. First of all, you need a very senior unemployed cardiac surgeon. A busy cardiac surgeon will never build a very large aneurysm practice, because these surgeries take from morning till evening. They can take 8 hours, 10 hours. A surgeon who has got a busy OT list, he can never do this. So since I am one of those unemployed cardiac surgeons here, I have plenty of time to build aneurysm surgery series. Then you need a finance department which doesn't calculate the cost of aneurysm surgery. If the hospital management starts calculating how much it is going to cost for an aneurysm surgery, you forget about building an aneurysm series. Policy to when we find a patient with very interesting aneurysms, like we get large number of patients with aneurysm jetting out of the chest, virtually pulsating, and they have no money. But we do their operation, and by doing the operation, we have learned so much, and this is the only way to build a large experience. And it's a great help to have a hybrid cath lab that will reduce the inconvenience significantly. And you need to have a very large ITU to accommodate chronic patients with multiple organ failures. In our hospital here, we have close to 350 critical care beds. So if 5 or 10 beds are occupied by chronic aneurysm patients, it doesn't bother us. Then you need a large referral base. Then policy to accept patients from government schemes. We have Yashaswini scheme, which gives only 60,000 rupees for a heart operation. If a patient comes to you with a large thoracoabdominal aneurysm, there is no way you can do it for 60,000. But then you can do it, you can improve your series, you can improve your experience. This is the way a large practice can be built. Thank you very much. Thank you very much for your patient hearing. Do you have any questions?